I'll be back. Let's see here. Good. Good day, Ahmad. Are you there, Ahmad? I'll unmute you. Doesn't matter.
Hi, Jean.
Hey, good morning. Good
How are
day,
you?
Paul. How are you, Paulo?
Very good. And you?
Good. You got your camera there?
Yeah. So I'll connect this.
Yeah, so how you been?
Well, good. Well,
Yeah.
always busy,
Yeah.
but yeah, it's a good
You-
thing. I see that you've been busy as well.
Yes. I love it. I love it. I love
Yeah.
it. I'm all day long. It's one after the other. It's great.
Oh, this
But
is
you know,
really.
yeah, I don't know if you remember. I remember we televised your spine a couple of years.
Yeah.
You had a really good tech there. I still remember him.
Yeah.
He was
No,
very,
they were the tech from the university, so they are very used to deal with this broadcasting and live streamings and yeah.
well, you know, there's not many people that are. You would think there would be, but a lot of the techs are in the old age, you know,
Yeah.
of film and
Yeah, and you need a lot of a lot of technology and a lot
yeah.
of
Now
things
it's
as well.
different. It's a different thing, and some learn it unwillingly, but they better get used to it.
Yeah. It's nowadays it is how it is, right?
Yeah, it's exploding now.
Yeah.
Before before Corona, it was there, but 10 million people a day were using Zoom. Now, 200 million a day.
Yeah, it's really amazing. We have receiving some emails about some security issues related to Zoom lately, but I don't know.
They've taken care of them.
Yeah,
Because a company that size, they're going to get the best.
Yeah.
A billion-dollar company, multi-billion-dollar company is going to take. I've seen it in the way I arranged the conference and the way they change things. I feel more secure. It looks really, to me, it looks tight.
yeah.
But hackers can get into Bank of America.
Well, of course.
They can do
Yeah,
that.
of course.
That's pretty darn. So
Yeah, nothing is safe, of course, but
it's a danger. But I think it's okay. Zoom now. I feel safe. I feel safe.
good, good.
So do you have a PowerPoint probably, right?
Yeah, so I will share the
You have the videos? Do you have videos at all?
Yeah, I have 1 or 2 videos there, but
they have sound?
It's embedded in the no.
Oh, okay.
No
Okay,
sound.
so you don't have to worry about the sound.
No, it is embedded in the PowerPoint presentation and no sound in it. So.
Well, I'm learning all the time. Embedding the video in the PowerPoint makes it easier, huh? Because as you know, sometimes it's difficult to leave the PowerPoint to play the video and then come back to the. It makes it very cumbersome.
Very awkward. And you share this, particularly when there are multiple participants. So it's become a little bit confusing to share the screen, and then you have to unshare so that the other one can share it. So
I know. I was let's see. I'm trying to remember the conference. It was for the European think tank students, medical students, and I just could not do it. I just could not go off one. No, it was with Vlad. That's right.
Well,
yeah, with him, because I had to get off the PowerPoint because he had a bad connection. I had to show the videos, and I just got so confused.
Now it gets difficult. Well, I try to make it simple, but well, sometimes it's not. Even in meetings, sometimes you have your presentation that works very well in your computer, and then you just upload to the system, and some systems don't work at all.
Well, I'm amazed there's not more issues because sometimes it's not easy to do when you're up there on the stage and you have to make adjustments. People are waiting. That's pressure.
That's true.
So are you ready to start?
Yes.
Okay, 10, 9, 8, 7. Hold on, let me get this off here. Hold on, I'm getting confused here. Clicking the wrong button. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning, this is Dr. John Bennett broadcasting from Miami Beach, home of Neurosurgical TV. Today we have the pleasure of having Paulo Pereira, with whom I televised the conference a few years back on World Spine in Porto. He's back today. He's going to explain the topic, and Paulo, welcome, and it's all yours. Take it away. Thank you.
Thank you, John. So let's try to share my PowerPoint presentation. Full screen. Is it working?
Yes, it is.
Great. Okay. So let's start with this. First, I'd like to thank John for making this possible, and to Professor Hypsharian for the initiative. I think it's really great. When I was a resident, to listen to presentations, we always have to spend a lot of money and to travel around the world. And well, nowadays technologies put this easier for us, and also it creates new opportunities to learn and to teach. So my name is Paulo Pereira. I'm a neurosurgically trained, but I'm a spine surgeon. I just do spine nowadays in Portugal, and this topic is about, well, minimally invasive OLIF. OLIF stands for Oblique Lumbar Interbody Fusion. OLIF is this technique is more known as a OLIF, but as a matter of fact, OLIF is a brand name for Medtronic. So we should call it anterior to psoas lumbar interbody fusion. Probably it's the more correct designation for that. So this is where I come from. I'm from Portugal. So Portugal is in the westmost part of Europe. As you know, and Porto is the second city of Portugal. It's well, it's a nice city with a lot of culture. It's a World Heritage City by UNESCO, and it's if you haven't visited yet, I look forward to seeing you here one day. So, as we know, we have a lot of possibilities for interbody fusion. We can go posterior, anterior, lateral, or wherever, but still, it's like a soup letter. But still, the workhorse of minimally invasive lumbar interbody fusion is still TLIF. So TLIF works very well. This is one of the papers we have published some years ago with an international study with 19 centers around the world, and well, the results are very good. This reproduces what you have. What you see in the literature, also in the short term and in the long term follow-up. So why should we think about other kind of techniques if we have a technique that works very well? Again, when you look at the picture after minimally invasive TLIF like this one, you can what you see depends on what you are looking for. So you can look at this like you see, well, the screws are correctly placed, you have a good interbody fusion, the cage is there, so probably the things should be, it seems good. But again, it always depends on your eyes and what you want, what you are specifically looking for. And you can see like that, but you also can look at this and see that you have no low doses there. And it's really difficult to get a low doses after a minimally invasive TLIF. This is also a study that we have published with some years ago with looking for our postoperative results, and basically the low doses that you get after a minimally invasive TLIF is about 2 degrees. So if your aim is to achieve some kind of low doses, probably TLIF is not the best thing to do. And we know from the literature that having the sagittal balance can be important, particularly for deformity patients. Even in after minimally invasive fusion, you have some data showing that the ODI increases as you get more unbalanced. And so when you look at patients that have bigger ODIs postoperative, they tend to have they tend to be more disbalanced in the sagittal plane. So probably getting a good sagittal alignment is important, even in simple cases like 1 or 2 level minimally invasive interbody fusions. So you still have some tricks that you can play with to restore sagittal alignment when you do a minimally invasive T-leaf. This is one option, like you see here is the isthmic spondylo, like a grade 2 isthmic, and playing with your instrument like this, you can push the superior vertebra backwards, and you can pull it backwards, and you can restore the alignment, as you can see here. You also can play with the cages, try to put the cages more anteriorly, using lordotic cages, but and the question at the end, you can even correct some deformities just with minimal invasive T-leafs. This is such a case. So we did asymmetrical T-leafs on the sides of the concavity. So we did the T-leafs on the left side on this in the lower part, and the right side in the upper part here. So at the end, you get a much better restoration of the sagittal and coronal alignment. Also with this kind of skin incisions. So let's try to. So basically the question is, are you happy with the lordosis you get or not? So if you think that your patient doesn't need to increase the lordosis, it will work very well. So a T-leaf is a great surgery, is the most common, for me, it's the most common minimal invasive fusions that I perform. But again, if you want to increase your lordosis, probably there will be other options, and that's what we are talking about. And other options can be going laterally. So what's the rationale to go lateral? One of the things is that you can put a bigger cage, and you can dock your cage in the ring apophysis of the vertebrae, so you have less chance of thinking in the postoperative. So you put a cage like this, it's typically like 5 centimeters long and like 12 or 14 millimeters height cage. So you have a lot of space to put your graft there. So when you do a lateral approach for a lumbar interbody, you rely on direct decompression. So you distract the disc space, you increase the foraminal height as well. So you increase the disc height and the foraminal height. You use a big cage like this, so you have more space to put your graft. And as I will try to show, you have more possibilities of increasing your lordosis and improve the sagittal and coronal alignment. So lateral interbody fusion, usually you can see that with the D-leaf or X-leaf. Again, D-leaf and X-leaf are also brand names for companies. So we should talk about this as a trans-psoas approach. Is the standard, is the first developed lateral interbody fusion technique going through the psoas. The drawback of this technique, as you see, is that your lumbar plexus is there. So when you go through the psoas muscles, you have more chance to damage the lumbar plexus, particularly when you go to L4, L5, where the lumbar plexus is more anteriorly. And again, so going through the psoas is not possible in L5S1 because the iliac crest is in front of you, and sometimes if you have a high riding iliac crest, you cannot sometimes you are not available. It's not possible to do it in L4, L5 sometimes. So if you go through the psoas, you should really consider to use neuromonitoring to try to decrease the likelihood of the injury to the plexus. So what are we talking about for OLIF or anterior to psoas or prep psoas approach? So the rationale is that instead of going through the psoas as a direct lateral approach, you go a little bit more oblique and anterior to the psoas. And what you do is that you have this window to enter the disc between the vessels and the psoas. So if you are more anterior, you will avoid all the lumbar plexus that are projecting here. So there is no risk or much less risk to the psoas, and you'll get it's still a direct approach, but your entry point in the skin, as I will show after that, will be a little bit more anterior. So this is a picture, intraoperative picture. So this is posterior, this is anterior. So this is the drawing of the posterior and the anterior part of the discs. So if you were doing direct lateral approach for both levels, you will put your incision here. So you go directly to the disc. With an olive or anterior to psoas, your incision will get about 5 centimeters more anteriorly. So again, this is the kind of trajectory that you see. So you don't enter directly lateral. So these were the drawings here. So this was the anterior and the posterior part of the disc. So this is anterior, this is posterior. And so your skin incision will be a little bit more anteriorly, and your trajectory will gonna be more oblique. So there are unique features of this approach. One is that, as I said before, you stay away from the plexus. So the plexus is here. So you go a little bit more anteriorly. So you dissect through the three layers of the abdominal wall. Yeah, you see the retroperitoneal fat and the peritoneum. So you do a blunt dissection with your finger to push the peritoneum anteriorly, and then you will touch typically you'll put your finger, palpate the transverse process. From there, you will see the quadratus lumborum is there. Here is the psoas muscle, and you go anteriorly to the psoas, and then you enter this area, as you can see here with this oblique approach. So doing this, you avoid the plexus, like I said before. Another unique characteristic is that your entry is going to be anterior to the iliac crest. So there is no limitation for high riding iliac crest, as you can see here. So this is a patient that you could not do a direct lateral approach. There is some questions here. Let's try. Okay, about the ureter. I'll talk about this. Thank you for the question. I will talk about ureter now. So the ureter basically comes together with your peritoneum. So when you push the peritoneum anteriorly, the ureter goes together with it. So you never see, or almost never see, the ureter. So let's try. So if you try to do this with a direct lateral approach, people will tell you, so this is not a good case for that, because you have the iliac crest projecting over your disc space. With all this, since you go more anterior, your incision will gonna be here, so you're gonna be anterior to the iliac crest, and then you will reach this more obliquely. This is another view. This is L5 vertebra. So for L5, you will have the ilium here. So as you go more anteriorly, you would go through here, and then you dissect everything. So the ureter goes together with the peritoneum, goes anteriorly. So, oops, going. Next case. So, okay, another one. So another difference from direct lateral approaches is that the positioning is very strict and very direct. So when you do a press-over approach, you just put your patient in a right lateral decubitus, and that's all. So you don't have to tilt the table, you don't have to bend the table to increase the. When you do a direct lateral, you typically tilt the table because you want to increase the size between the ribs and the iliac crest, and then you try to have an orthogonal approach. So you rotate the patient to the you rotate the table until the disc is perpendicular, direct perpendicular. The other thing that you should do when you do a transpsoas approach is to flex the upper leg to decrease the tightness on the psoas, so the psoas is more relaxed. In a press-psoas approach, you don't have to do nothing of this because you are not. It's even good to have the psoas more tight because you palpate it more easily, and since you are going anterior to it, you will not injure anything. So it's a true direct lateral approach, direct right lateral positioning, and nothing else. And the other thing is also better for ergonomics. So you stand anteriorly to the patient, so you are in front of the patient, and your X-ray can still be there. So you can still be working with your X-ray in place. So opposite to a direct lateral, you don't have to have your all the time your C-arm going in and out. So so you are going more anterior to this. And so you keep, as I said, you can keep the C-arm in place because this is your approach, or you are going more anterior to that. So these are some of the advantages of this technique, and you also have less risk of neurological symptoms because you don't injure it, you don't touch the plexus, you stay anterior to the plexus, and you have less risk or psoas hematoma because you are anterior to the psoas. Still, it's very important to check your anatomy. I will come back to this. So look at you don't need to do a CT angiogram before, but you should look at your CT scan, and for instance, if you have you can have look at your vasculature. Sometimes you have the veins in front of the disc, and you have to decide if you have enough space here to go. For instance, in this patient, you have a lot of veins here and the artery, so it would be difficult to get a good approach on this patient. So I will try to show briefly how it looks like in a surgical video. So let's try, and I will stop and see what we have been saying. So it's the right, so back. So it's the right lateral decubitus, as you can see here. No tilt on the table, so you just tape to secure the patient, and then you drape. And then these are the marks that you typically don't need to do, but that gives you an idea where you are. So this is posteriorly, this is anteriorly. So this is the posterior margins of the discs. So again, your entry point is about 5 centimeters anterior to the anterior border of the discs. So again, you do your skin incisions, your skin incision. The first thing I do is that, oops, sorry. Next thing I do is always I go to get bone from the iliac crest. So I retract so the iliac crest will gonna be here. So I just retract the skin and the subcutaneous tissue. I open the thoracolumbar fascia in front, the external oblique fascia over the iliac crest and remove bone for grafting. So this is what I'm showing here. So opening, this is the iliac crest, and I'm removing graft there. And then I close the fascia there and go directly where I want to go. So I do a different opening of the fascia if you want to collect bone. If you use an allograft or BMP or whatever, of course, you don't need this step. So now we're gonna open the external oblique fascia here. So this is gonna be the external oblique, and then you have to, so you just dissect the fibers, dissect parallel to the fibers. Then you'll have the internal oblique here with the fibers running perpendicular. And then you dissect the internal oblique. So external oblique here. Internal oblique there. And then this was the transverse, and this is already the retroperitoneal fascia. So after opening the fascia transversalis, you will see this retroperitoneal fat. And then you'll start dissecting and pushing the peritoneum anteriorly. So this is the genitofemoral nerve. So this is the psoas muscle. So we are going anterior to the psoas. So this is still the same. We use this first. It's a modified like Jamshidi needle because it's blunt. This was designed to use with neuromonitoring. So I don't connect this to neuromonitoring in anterior to psoas approaches, like I said before, but I still use the same introducer because it's blunt and it doesn't damage any vascular structures when I operate. So you put it in the disc, you check in the X-ray, and then you use your dilators. So the peritoneum and all the abdominal content was displaced anteriorly. So this is the front of the patient again. This is the back of the patient. So after that first introducer, you put the K-wire inside, and then you put all your dilators around the K-wires to reach the disc, as you are going to see here. So these are the dilators. And then you will have this kind of retractor that you fix to the table to keep it in place. You block, so you block it there, and then, oops, back, sorry again. What about here? And also an important step to help to get it more fixed is that you use a screw in the you use this as this screw goes in a small orifice that you have in your retractor. So this retractor have a little space to put a screw that helps you to stay much more stable, so it doesn't move a lot at all during your surgery. So this every time so again, so again here, so you will have your working channel here. So this is your retractors, and this is the screw that docks in the upper or the lower vertebra to help gaining stability. So then you will have a little bit of you just burr small soft tissue that you have in front of your disc. So again, if this is anterior, your psoas will be retracted anteriorly. So you are anterior to the psoas, so the psoas will be here. So this is anterior, this is posterior, so the psoas will be there. So this is the disc space directly. So you do your opening in the disc space, and you prepare. You cut the annulus and you do your discectomy as if you were doing a nail lift. So you just have a big space to work. So you have the shavers, you have the curettes to remove as much as possible of the disc. And then you check in the X-ray the size of your. It's important that you keep it anteriorly. And another important thing that you are going to see here is that once you go in the disc and you want to, and you start to put your cage and to prepare the contralateral side of the disc, it's very important that you cut the annulus on the contralateral side on the disc, and that you do what's called an orthogonal maneuver, so your approach is oblique from anterior to posteriorly, as you can see here. But if you progress like this, you can enter the canal on the contralateral side. So to avoid this, you will have to push your hands backwards so that you go perpendicular to the disc. I'm gonna show you this here. So this is to cut. So this will gonna be to cut the annulus on the contralateral side. As you see in AP that your cob goes past the vertebral body, so that you cut the contralateral annulus there. Then this is the template. And this is the cage. And as you're gonna see, I will put the cage perpendicular to the patient and perpendicular to the disc space. So you enter like this, a little bit oblique, but then you have to, you have to go backwards so that the cage is inserted there. And so this is final. So I always, so this was a 2 level. So this is the second cage, again perpendicular to the patient, and the 2 cages are there. So when you start removing it, you start removing the retractor, the psoas is there. So you were all the time anterior to the psoas, and all your abdominal content and the retroperitoneal fat will come into place again, and you will see the three layers, and you open. I always back this up with the percutaneous screws posteriorly. So what you gain with this? You gain low doses, as you can see on this patient. This is a patient that was kyphotic, and you see that the nice restoration of the low dose is here, and you can restore sagittal or coronal alignment when you do multi-level. You see this patient with this kind of coronal imbalance that was corrected after a 3-level Olive, and again, the same regarding the sagittal alignment. All of these discs are collapsed and parallel to each other, and you get a very nice low doses here. This is another example with the lateral aesthesis that was corrected with the 2-level Olive or press-psoas approaches. So this is not for major deformities. This is basically what you get. With lateral approaches, you get about 10 degrees of lordosis for each level that you perform. So if you do like a 3-level, you will end up with about 30 degrees. That's very similar to what you get with the pedicle screw, a pedicle subtraction osteotomy, and you will have a more smooth lordosis because you gain some lordosis in each level and not all the lordosis in the same level. You can increase it. You can increase the lordosis using hyperlordotic cages because they are easier to use in the lateral, to position in the lateral approach. Comparing to posterior approaches, you can gain more lordosis if you resect the anterior longitudinal ligament. It's what's called anterior column release. This is typically the maximum correction that you can get. So if you have a patient with a major disbalance, probably you should not use this kind of techniques. So when you compare lateral approaches to posterior approaches, like PLIF or TLIF, there are some advantages. Of course, you don't go inside the canal, so the risk of having a dural tear or nerve root injury or injury to the dorsal root ganglion is basically avoided. And so you have no epidural fibrosis as well because you don't go inside the canal. When you compare this to typically anterior approach like an ALIF, you have less risk to the anterior vascular structures because you are in between the vessels and the psoas. You also avoid the sympathetics and decrease the risk of retrograde ejaculation and all these kind of complications. So there is also an alternative to go to L5S1 that is something you cannot do in the direct lateral approaches. So in XLIF or DLIF, you cannot do L5S1. Here you can do it, but basically the approach is like an ALIF. So basically, OLIF between L2 and L5, you go between the psoas and the vessels, and when you do L5S1, you go below the bifurcation of the vessel. So basically, OLIF 5.1 is like doing an ALIF in using the patient in a lateral position. The main advantage for me is that the abdominal contents stay away, so you don't have to, so it's easier to go, and particularly if you have patients that need L5S1 and also L4-5 or 3-4 interbody fusions, you can have all of these with different incisions, but with the patient in the same position. So this is what I was telling about the abdominal contents. So since you are in the lateral position and after you retract the abdominal contents, so you can, they will not be in your in front of you. So the position is still the same, right lateral approach, and the incision is different. So basically what you measure is you measure the projection of the L5-S1 disc, and this can be like this or much more oblique depending on the pelvic incidence and the shape of the pelvis of the patient. And so your incision will be about 2 finger breadths anterior and above the iliac crest, and in between the vertical line that comes from the center of the L5-S1 disc and the projection of the L5-S1 disc. So if you project anteriorly this disc, the orientation of L5-S1 disc, and this, if you continue this line anteriorly and you do a second line, a vertical line in the center of L5-S1 disc, your incision will be in between these two lines, about 2 finger breadths anterior and superior to the iliac crest. So the other thing is that you still have your approach will be lateral to the rectus muscle. So this is, so you go lateral to the rectus. So this is your entry point for L5-S1, and the rest is the same. So you dissect, you push the abdominal contents and the peritoneum anteriorly. Again, so this is you sweep off the peritoneum from the psoas and you go more anteriorly here. So you palpate the common iliac artery on the left side, and then you go anterior to that. And so typically what you're gonna get is a space between the left common iliac vein and the right common iliac artery. That's the most typical, the most common anatomy here. So again, as I was saying before, and regarding the question that I had before, when you sweep the peritoneum, the ureter typically goes together with it, to go together. So all of this comes together, and you push all of these structures anteriorly. So you're gonna get your space here. So you have, using this, you typically have this kind of retractors, not the tubular retractors. So those retractors were designed for this approach as well. So you have one retractor that is like this. So it's like the retractors that you use for cervical spine. But again, it has a space to put a screw there. So you palpate, you dissect the left iliac vein, you retract a little bit the iliac vein, and you put this retractor and secure it with a screw, and then the other one will go around the disc space, and the vessels will go together with it. So at the end, you'll have this kind of, you can put a third retractor cranially if you need it. It depends. Not all the times you need this third retractor. So this is the left retractor. This is the right retractor, and this is going to be the disc there. So you can have limitations for these approaches, of course. If you have, I will talk about vascular anatomy in a few moments, and It can, of course, if you have patients with thrombus in the arteries, with lower extremity arterial insufficiency, patients that are morbidity obese or have a lot of scar in the abdomen from previous surgery are not the best candidates, of course. And this is what I was talking about regarding vascular anatomy. So in front of L5-S1 nerve root, typically the space that you have in about 2/3 of patients is in between the left iliac vein and the right iliac artery. So this is the most common. So the artery you typically have no problem because it will stay away when you put your retractor here. It will push the artery laterally, but the iliac vein typically you have to dissect a little bit so that you can have the retractor on your side. You also have variations. Sometimes it's also the veins in both sides, so you have to look at your vessels. The other thing it's important, again, this is a demonstration of what you can see in the CT angiogram, is that typically in front of L5-S1 disc you have the left iliac vein. This is the artery here, so you had already the bifurcation of the internal and external arteries here. And on the right side, you typically have the artery more medial than the vein. So it's easier to put your dissector here and your retractor there. So again, it's important to look at the size that you have for your approach. If you have a small percentage of patients can have a very narrow window here. So probably if you have a patient like this, this is not the best approach for this patient. And of course you can have different kind of variations, like internal iliac vein coming not from the bifurcation but from the left iliac vein. So you have to look at those possibilities. Another thing I like to do to see in my patients is that if I have some space here in between the left iliac vein and the disc or the periosteum. So when you have this, you don't see this space. It doesn't tell you that you cannot. It doesn't tell you that you cannot do your surgery, but it's much more easy to dissect here than to dissect here, because this will be more packed together and more stick, and it's gonna be more difficult to dissect. Again, typically what you have, left iliac vein here, right iliac artery there. Of course, you can have complications like infection, you can have a retroperitoneal hematoma. So when you remove your screw and the screw that is holding the retractor, you have to look at that and see if everything if nothing is bleeding, and of course you can have abdominal injury to the abdominal contents, and you can have a transient postoperative ileus as well. So when you do when you can do this, you can combine patients that need multi-level fusions. You can use a press-OS approach on the upper levels, and the A-leaf, let's say, A-leaf done in the lateral position for L5-S1. And again, this is the position of the retractors that I showed you. Typically, you have this is the first retractor that you put, trying to hold after dissecting the left iliac vein, and keeping it in place, and then the other dissector goes to the contralateral side, and you can put a third retractor if needed cranially. So, and this is what you can do. As you can see, you can combine. This patient has 3 lateral interbody fusions, L2, 3, 4, and 4, 5, like in a press-over approach, and with the patient in the same position, we did L5S1 O-leaf. So it's an A-leaf then in the same lateral decubitus position, and then the percutaneous screws posteriorly. So shortly, I will end up with 3 cases just to explain what we are doing and why in cases in which cases we are doing that. So this is a 51-year-old lady with mainly low back pain, but also pain radiating to the left thigh, to the knee. It's been progressive, worse on loading, with standing, walking, and improves with when she's resting. No neurology, failed conservative treatment for more than 1 year. And this is the MRI, the sagittal MRI. So you basically see a grade 1 degenerative spondylo with some disc bulging as well, creating stenosis in the canal, and you have this kind of the tortuosities of the nerve roots. That is a major sign of lumbar stenosis, as you know. And you also have on the left side foraminal stenosis. That's what is causing the left side pain. This is the compression of the L3 nerve root in this foramen. So this patient has a central and the left foraminal stenosis. So this is the right, so on the right side is okay. This is the X-rays, so a grade 1 degenerative spondylo, and minor asymmetrical collapse of the disc, and nothing very different on flexion extension. So this is extension, this is flexion. So this is the lysis is about the same. The coronal and sagittal balances are not so bad as well, as you can see from here. And this is what we did. We did a lateral approach, and we could restore this height. We lost some of it because, as you can see here, this is also to show one of the possible complications is that you have some sinking of the cage in the lower vertebra. So this can happen particularly when you are too aggressive on removing the disc and on using the shaver. So if you use the shavers too aggressive, you can injure the end plates, and you can with that you lose the part of the possibilities to restore your lordosis. So this is pre-op and post-operative. Second case is another lady, 56-year-old, no major comorbidities, low back pain for more than 10 years that has been progressive. This is her main complaint, and also neurogenic claudication during the last 2 years. Also progressive. Now she has a walking distance of less than 500 meters. And she tried a lot of different things, medications, rehabilitations, epidural steroid injections, some improvement, but not enough, and the walking distance is worsening. So this is the sagittal MRI. Again, you see this kind of spinal stenosis. Again, the tortuosities of the nerve roots, the serpiginous shape of the nerve roots here, and you have a central stenosis in L2-3, 3-4, and 4-5. In L4-L5, you also have a disc herniation here, an extrusion going caudally. And in L4-5 and 3-4, you have a degenerative spondylo grade 1, as you can see here. L5-S1, no stenosis, and the disc is not that bad as the other levels. So this is the X-rays. So again, the degenerative spondylo in L3-4. That's worsening on flexion comparing to extension. When you compare the slip is bigger on flexion than extension, and the other levels are okay. So putting all of this together, of course, doing the decompression alone probably is not a good thing, particularly for L3-4. So in L3-4, this patient has a spondylo that possibly would progress if you did just a decompression. And also you could do a decompression on the upper and lower levels, but also there is a lot of back pain. And there was a disc here, disc herniation, as you remember, in L4, L5. So we decided that doing a 3-level fusion could be a reasonable option, trying to deal with all of the problems together. So this is, again, the sagittal and the coronal profile were okay. And so we did the 3-level lateral approaches. So we gained some low doses here. With a press-over approaches. Also, you can see here that the more anteriorly you put your cage, the more low doses you get. So this is a little bit more posterior, and low doses is not that good. And the other thing still is quite better than before surgery. And the other thing I'd like to show you is this postoperative image. So even the disc protrusions that you have before the surgery. So this is the preoperative. So we didn't do any posterior approach. We just did the percutaneous stabilization, pedicle screws percutaneously. So we didn't go inside the canal, and we didn't go posterior to do any kind of decompression. And as you can see here, since you distract the disc space, the infolding of the yellow ligaments disappear, and you gain, this is what's called really an indirect decompression. Even the discs, even the protrusion, the small disc herniation that we didn't address directly. So you don't have these tortuosities of the nerve roots, you have much more space just doing anterior approaches and just doing distraction of the disc space. So this is what I would like to show you in a postoperative comparing to preoperative MRIs. And last case is a 45-year-old lady with radicular pain in the left leg down to the tibial crest for 2.5 months, multimodality conservative treatment, also some decreased sensation, so some sensitive neuropathy, and some moderate low back pain, which was not the main complaint. So the main complaint was left leg pain, and this is the MRI again. So you have this disc herniation and degenerative spondylo, again grade 1, as you can see here. And we also did a lateral approach to address all of this, to increase the foraminal height as well, to increase the size of the disc space, as you can see here. And again, this is pre-op and postoperative. Here on a CT scan, the cage is there, and this is the spine, the case you can gain. Lastly, this is a lady with neurogenic claudication of over 18 months, and this is here because this is to show you that this is the cases where I don't consider going laterally, because you have a lot of bony stenosis. So you have calcification of the yellow ligaments, you have a very tiny canal, very severe stenosis, and on cases like this, I still like to decompress directly the canal. On this case, we did a midleaf that is basically a posterior approach, a posterior decompression, just decompressing all the thecal sac. And the only difference to a conventional approach from the midline is that you have a much smaller incision here because you have this different trajectory of the screws. The different trajectory of the screws that you put, it's what's called cortical screws, because you enter from caudal to cranial and from medial to lateral, so you don't have to expose as much. But this is the kind of patients I don't like to do on indirect decompression and try to rely on direct decompression and seeing the dura and the nerve roots. And again, it's always a question of the hammer and the nails. And if you have different options in your armamentarium, possibly you can better tailor what you want to achieve to the patient you have that is in front of you. So I'm not saying that, like I said in the beginning, considering minimally invasive lumbar fusion, the T-leaf, minimal invasive T-leaf, is still my standard technique, but I try to show you that the going lateral and particularly going anterior to the psoas can have advantages in a set of patients, in some of our patients, and is an option to consider. So I'll be happy to answer questions in case you have some.
Okay, Paulo, thank you very much. Okay, this is a very interactive. Paulo's experienced at giving these presentations, so he knows how interactive it can be, and we encourage people in the pay. You want me to get you off that, Paulo? I can okay. Just, yeah, I can okay. Get you. I basically.
I just to share the screen, right?
There you go. You're off the screen now.
Okay. So
okay.
Just go to the okay.
Did you want to get back on the PowerPoint or?
No, that's good. That's good. So
okay, let's see
Durator, I have replied to this. Which type of anesthesia I do the procedure? I do these procedures with standard general anesthesia. So all of these patients are done in a general anesthesia, and I have the patient in lateral positioning, and then I tilt the patient to do percutaneous screws. On some patients, so I typically do the second phase. So the percutaneous screws I typically do immediately after the lateral approaches. The exceptions are some patients that I might be concerned with the indirect decompression, and I want to be sure that after indirect decompression they don't have radicular symptoms. And on cases like this, sometimes I stage the procedure. So I do the lateral approaches, and then I have the patient walking in the ward for the next days. And if the patient still have radicular pain, when I do the posterior approach, I decompress that nerve root. But typically it's done in the same procedure. So another question from Genial: any experience of using Pivox plate or you use percutaneous pedicle screws? This is also another a very good question. That are some cages that including have embedded some fixation device, either a hole for screws that you can put, something similar that you can use for some cervical or A-leaf cages. So you have like a through where you can put a screw, or you can or some cages have kind of blades that you hammer, and they go in the upper and lower vertebra. And also the third possibility is doing a lateral plate, as you say. I prefer using percutaneous screws because I feel that they are more stable, particularly in flexion. When the majority of cases that I do, I have deformities like I showed you, or have degenerative spondylo, so I feel more comfortable to have percutaneous screws that restrict flexion better than a lateral plate. But still possible, particularly for patients that don't have a major instability. I think that using just lateral fixation can be a good option. I know that some surgeons are also using these cages as standalone, so nothing posteriorly. Well, I'm a little bit reluctant to do this. As you know, the literature showed us that standalone cages are not good for A-leaf. So why should they be good for a lateral approach? But again, if you have no major instability, or if you have only degenerative disease, eventually putting just a cage can be okay. The other thing is that a few patients that I have staged for the reasons that I said before, that I do the posterior, the lateral approaches on one day, and having the patient walking on the ward to see if they have radicular symptoms after that. Typically, those patients have significant back pain in the last few days that disappear once you put the percutaneous screws. So that's the reason why I keep doing percutaneous screws. Also, it's a fast thing to do, and we are very used to do that. So next question from Ahmad Abdullah is, where is the patient stay in the hospital? It's about 2 days. It's about 2 or 3 days maximum. Usually the standard is the patient stands up the next day, walks around, and if everything okay, the second day he is discharged. So there's also a question from Gonzalo Gomez. How does the fat influence the surgery? Are there papers about this topic? The difficulty of the fat patients tend to have thin peritoneums that are more difficult to dissect, and the bigger the patient is not just the fat, but the bigger the patient, the most difficult it is to reach the lateral side of the spine, and you have to use a longer tube, a longer retractor. So when you use a longer retractor, it's more difficult to work because you have to put all your instruments through that tube, and the longer you have, the less possibilities of angulations. But we have done it on fat patients. The patient I showed you the video, as you could see from the first image of the positioning, it was a fat patient and we had no problem at all. So directly answering, I think there is no contraindication, but it can increase the difficulty of the surgery.
Okay, do you see any more questions, Dr. Pradella?
Okay, so
Okay.
with that,
Yeah, let me just see if the panelists, does anybody have any questions they want to ask directly to Dr. Pradella? Hello, Abhilash. Good day. I want to introduce you to Dr. Pereira.
Yes. Good morning, Jim.
Hi, Abhilash.
Yes, good morning.
Good
Hi.
morning. I'd like you to meet Dr. Pereira.
Hey,
Dr.
Dr.
Pereira.
how are you?
Yeah,
how are you?
he's a
Where
big
are you from?
Tampa, Florida.
Ah,
Yes.
Yeah,
Big
good
Ro-
weather there, right?
Yes, big Ronaldo fan. So
Okay.
yeah.
I'm not a soccer fan, let me tell you.
I didn't hear that. So
Okay.
Yeah, you got Brady now, right?
yeah, we have Brady. That's right.
Well, things are going to change, I think, in Tampa.
Yeah.
But yeah, Dr. Pereira is a very prominent spinal surgeon from Portugal. And he gives conferences. So part of the value of this is networking, meeting who's out there, and matter of fact, Dr. Goel, how you doing? Are you here already? Because I know he had surgery scheduled. He may have stepped away. Is there anyone else that wants to meet Dr. Pereira? Julius, do you want to meet Dr. Pereira? I'm kind of pushy, Abhilash. Well, that's okay. If someone doesn't, that's fine. Okay, very good, Dr. Pereira. We'll have this edited and be sent to you. And I thank you for your time.
Thank you very much, John, for doing it and for making this possible. And I hope this can be useful and effective for training for the participants. Thank you, John.
Thank you. Okay, very good. So that one is ended. We'll edit it. And I'm surprised Atul said he had surgery. So I'm surprised to see he came. I expected him to come in about like an hour. Are you there, Atul? I see you checked in. See if he wants to give his presentation now or wait until 6. Yeah, just a second. I'll try to get a hold of Dr. Atul.
John?
Hey, there's Atul. Okay.
John, you think we should wait till 6 o'clock?
Well, it's up to you. It's up to you. I expected you to be in surgery. So this is
I came back. Actually, I have to just get a hold of my slides and all. So you think we should, now it is only 4:40.
Well, whatever's convenient for you, whichever.
Because you have given time at 6 o'clock.
No, that's okay. That's okay. We can, well, either way is fine with me.
Okay, why don't you involve Paulo with some questions and give me 10 minutes? Is that okay?
Yeah,
We'll
that's
start at
fine.
5.
Okay,
We'll
that's
start
great.
at 5, okay?
Okay,
Okay, John.
very good. Yeah, and anyone is open if you want to ask. I don't know if Paulo's still here. He may have stepped away. So we're just going to sit here and wait for Atul, okay, everybody? So just stay in your seats. Dr. Guel said he'll be here in a few minutes. to your backer tool, right? Sorry. Hello, Big Daddy.
Yes, sir. Are we waiting for Atul, Professor Atul?
Yeah, he just arrived, I think.
Okay. We are eagerly waiting.
Hey, John,
Yes.
this is Abhilash. I mean, since we're waiting, why don't we have, if anybody wants to introduce themselves and tell us what their interests are and where they work, and if they want to
Yeah, that'll be fine. That'll be fine.
put your email in the chat box, this way we can connect and, collaborate since we're waiting.
Yeah, sure. Does everybody hear that? If you want to introduce yourself.
I mean, I'll start with me since,
Okay.
so I'm Abhilash Haridas. I'm a neurosurgeon here in Tampa. I've been in practice about 10 years now, and my main interests are pediatric neurosurgery and vascular neurosurgery and skull-based. So obviously with Dr. Goel's talk, it resonates a lot with my interests, so that's why I'm here. And yeah, I'll leave my email address in case you want to connect offline. Go ahead to the next person.
Yeah, anyone that wants to introduce themselves, step forward.
Okay, Zekano, I am an associate professor of neurosurgery at University of Lagos College of Medicine. I have been there since 2007, and my major interest is in skull-based surgery, neurovascular, and tumor oncology, neuro-oncology.
In Nigeria, right?
Nigeria, yes. I'm in Lagos, Nigeria.
Lagos, Nigeria. Okay, the next person to introduce themselves. Don't be shy, you're neurosurgeons now. Or some neurosurgeons, probably some students mixed in here. Maybe some residents. Well, I'll introduce myself. I'm John Bennett, the owner of this website. When I first saw the video technology through Google Hangouts, I was amazed. I thought the power of visual interaction, I think, is the key. That's the most effective part of education. It's evidence-based. The most effective form of education is interactive. And this platform affords that. So that's why we're doing these in neurosurgery. I just happened to meet some very tech smart neurosurgeons such as Ike Cherian, and he has introduced me to many neurosurgeons. I went to Nepal for 3 months with Ike, and Yuha was there at the time. So we had a conference. We met a lot of people. It allowed me to establish a network, and we're continuing to grow, especially with it's actually a boost, this Corona. But anyways, we're open to ideas. Anybody has ideas about putting on conferences? One of the benefits of this technology is you can put on conferences very quickly. We put together a conference for the pituitary gland based basically in Spain. Most of the neurosurgeons are Spanish. But that's how long it takes to arrange a webinar or a conference, a week, even less than that sometimes. You can have 3 or 4 talks or whatever. Just let me know the topic, and we set a time. And then the protocol, the way I found it works best is that if you make a calendar and say, hey, we're doing a webinar on this, fill in your time that you want, because it's once you have to get in touch with someone again, oh yeah, I want to do the conference, but then they're hard to get a hold of. So it's a little step, but just contact me and I'll lead you through it.
Yeah, John, you've been instrumental in getting this going and keeping it going. I can tell you my personal perspective, since I've attended numerous webinars like this of yours, is as neurosurgeons, we're here to we're here to operate, we're here to do surgeries, and without being able to go to the operating room now, this is a incredible venue for learning techniques. At least here in the United States, the residents are only allowed to work 80 hours a week. That's what the educational standards are. It wasn't like that 10 years ago. So many times when you are in the middle of surgery and you have to leave if it's 5 p.m. So you don't really get to see the end of the surgery. So sometimes when you come to these venues, you can witness surgeries from start to finish and really appreciate the energy and time it takes for some of these cases, which can take you pretty much all night. So I think I'm speaking for the trainees that this is pretty much like Ike mentioned, it's a lifestyle, and we're all here because we believe in that lifestyle and want to make the most of it and have a perfect work-life balance to keep us all successful. So yeah, those are my comments on what I find useful in this technology. It's 7:30 in the morning here. Usually I'm starting surgery by now, so it's just very quiet at this point, but I'm hopefully going to make this a regular hangout so I can get the most out of it, and of course connect with neurosurgeons around the world, which is always enriching for me personally. So
yeah, you can help me actually a little bit. The way that you guys help me is networking, basically. Because you'll run into someone who says, oh, Dr. Bennett, so-and-so wants to talk about this. And that network kind of grows. And the people are if I have speakers, I can just call on people, and the network's expanding and it's getting better. I mean, meeting Dr. Goel, look how quick that happened. I mean, I didn't realize how big he was in the neurosurgery world because I'm not a neurosurgeon. Mm-hmm. But when I mentioned that to another neurosurgeon, they said, "What? Is he there now?" It was, it's, and I'm trying to get someone. Well, I'm not trying, but in conjunction with Ike, we're trying to get the masters to put more webinars on, because this is one time in history, very unique, where neurosurgery residents are at home. That's not going to happen again in my lifetime, probably. So now's the time, I think, for the masters to step to the fore, take the opportunity, talk to the neurosurgery residents, because they're going to be too busy to see you if you're on again. But anyways, that's one approach I'm going to try. But let's see here. Are you there, Atul? Let's see here. Let me check. Go ahead, Big Daddy. You have something to say?
Yeah, it's nice having you here. Which city are you in the US?
He is here, but he is muted.
Oh, you're in UK.
No, I'm saying like Professor Atul is here, but he is muted.
Oh, okay. There he is. Okay. So Neil, your assistant producer, I guess I owe you some money.
I'm not assistant professor.
John.
I'm a resident.
Okay.
What is happening, John?
No, well, I just had an assistant producer barge in, and he's demanding a pay raise already.
Okay. So you think we are ready to?
Yeah, we're ready to go.
Okay. So let me just set up myself.
Yes.
Okay.
Perfect.
So should we begin, John?
Yes, please.
Okay. You want to start or something?
Yeah, sure. Okay, you mean introduce you? Okay, I'll start, yeah. Hi, this is Dr. John Bennett from Miami Beach, Florida, home of Neurosurgical TV. We are graced with the presence of Atul Goel, a master teacher in neurosurgery, and you'll see what I mean if you watch him. He's going to talk about epidermoids today, and we'll start right off. Welcome, Atul, and thank you.
Thank you, John. And thank you all the participants. Because we have time today, so I like to go slow. And I want to be more beautiful because epidermoids are slow growing, beautiful tumors of the body, of the brain. Epidermoids grow slowly over several years. And they are called pearl-like tumors. Obviously, these pearls are beautiful tumors. But I must tell you that these are not so beautiful. Now you will ask me why they are not beautiful. And I will like to why they are not beautiful. Maybe more beautiful people are more dangerous people. They are, you know, one of the most thankless tumor, if you would like to call them thankless tumors, because they present with very marginal symptoms, very few symptoms. They present when the tumor has actually grown in the corners of the brain, corners of the blood vessels. They have encased the blood vessels. They have gone from this side to that side of the brain. And symptoms are very marginal. When the symptoms are marginal, the neurosurgeons are faced with a bigger challenge. So you have a tumor which is here and there and everywhere with marginal symptoms. So you are not supposed to harm the person, and you are supposed to treat him. So it is a difficult situation for them. So let me discuss with you this unusual tumors, relatively rare tumors. But I must say I have got a very good association with these tumors for several years. And without any doubt, I can say that my experience with epidermoids is largest in the world by far. And I will show you. So as I mentioned to you yesterday, brain is nothing but sunken skin. Brain is originated from the epidermal or epidermal layer, and then it sinks in like neuroectoderm. It turns in, it makes a groove, and then these grooves develop into brain. So brain is nothing but sunken skin. And this statement is such a wonderful statement to make, but it is actually true. And when the brain sinks in, the epidermis also sinks along with the brain. So brain is neuroectodermal, ectoderm is epidermal, and this is how epidermal tumors involve the brain. So what are the characters of epidermoid tumors? So these are some beautiful sentences I have made up for you. They proliferate slowly to acquire bulk over several years through discrete silence. So they will be silent for a long period of time, and they acquire that bulk by growing slowly and proliferating slowly over several years. And even when they show up by virtue of the symptoms, these symptoms are very marginal or here and there. So they can be called gentle manly tumors. but whether they are really gentlemanly, that you have to see for yourself. So wherever there is space in the brain, they grow into that space. And that is their character. So space in the brain is in the subarachnoid cisterns, in the region of the ambient cisterns, in the region of supracellular cisterns, in the region of interhemispheric cisterns, around the region of the tentorium, above and below the tentorium. So more often, these tumors, the space is more pronounced in the region of the tentorium and in front of the brainstem and anterolateral to the brainstem, in the CP angle cistern, in the cerebellomedullary cistern, in the cerebello-midbrain cistern. These are the cisterns where there is tumors, where there is space in life, and this is the space where these tumors grow. I made one sentence in one of my lectures that these are like Mumbai slums. Wherever there are space, the slums show up. Similarly, these tumors find space and they grow up in that space. Epidermoid tumors, neural crest cells are migrant cells. These cells are sitting on the fence. They are neither neural, neither clearly ectoderm, but bit of both of these tumors. And if you want to go in more of these kind of philosophical issues, you must read one of my papers, and that paper is, I had written one editorial, The Heuristics of Craniospinal Epidermoid Tumors. You must read this paper. I will say it is a beautiful paper that you will love to read. So these tumors can grow in the sylvian fissure like this. And here they can be involving all the arteries of the sylvian fissure. And you know, there are several arteries. So they may be beautiful looking, but because they are beautiful, these arteries get hold of them very intensely and very intimately. And this is the relationship where that can be disturbing to the surgeon, because any single artery, if you damage, you can create a very big deficit. The most important issue in these cases, surgery-wise, that these are absolutely benign tumors. They have some beautiful characters like softness and amenability to suction, and all those things are there. But you take one vessel, you demolish the person. So this is the sylvian fissure region, epidermoid tumors. Now you see this is another huge tumor. You can imagine the internal carotid artery, the bifurcation, the basilar artery, the contralateral internal carotid artery. And when this patient comes and you see the subarachnoid spaces are very prominent, this is not a tight brain. The patient has hardly any symptoms, maybe a little bit of ataxia here and there. And this poses a very big challenge. That is why I say this surgery on these tumors is quite a thankless job, because all you can do is harm him, because the symptoms in any case are not prominent, and damaging the patient is a big possibility. By damaging the arteries of the circle of Willis, you take one perforator, you completely damage and kill the person. They are in front of the basilar artery, behind the basilar artery, front of middle cerebral artery, behind the middle cerebral artery. They are around the pituitary stalk. They are all over. The symptoms are extremely marginal. This is another huge epidermoid tumor. And you see these tumors have been traditionally called CP angle epidermoid. But I will show you that I have completely demolished this name or nomenclature of this epidermoid, because these are not CP angle epidermoids. These are under the tentorium, and I have labeled them as tentorial-based epidermoid tumors because they not only go in the CP angle system, they go into the cerebellomedullary system, cerebello-midbrain system, and then in the ambient system, and then in the supratentorial compartment. This is another suprasellar, if you want to call it suprasellar epidermoid tumor. And you see the relationship with basilar artery, relationship with internal carotid artery. More important is not in this case, but it can go in front of the basilar, behind the basilar. It essentially means that the perforators are traversing through the tumor, perforators are traversing through the tumor, and very intimate kind of relationship that this beautiful tumor develops. And that is what makes the surgery on these tumors little bit difficult. I will not say these are difficult surgical issues, but can create some issues during surgery. This is another tumor. So I'm taking you to the world of epidermoid tumors. And I want you to enjoy this world of epidermoids. So this is the tumor on both sides of the forks. And you see how the tissues are displaced in here and there and everywhere, as if they are running away from the tumor. This is another tumor on both sides of the forks, intimate relationship. I do not know what the symptoms were at the time of presentation, but I can tell you the symptoms may be extremely marginal, maybe a convulsion, maybe some kind of headache, maybe a little bit of ataxia. But essentially, the symptoms are quite marginal and ignorable. This is another huge tumor. You see how these tumors go from here and there and everywhere. Pineal region cistern, posterior third ventricular cistern, epidermoid are relatively common. I will say ambient cistern or tentorial-based cisterns, tentorial-based epidermoids are the most common. And next to that is pineal region epidermoid is next common. And then there is falcine, interhemispheric falcine tumors are the commoner. Then suprasellar epidermoid tumors are common. Now I want to show you this beautiful slide. Carefully see this. This is pineal region epidermoid tumor. Carefully see this slide. And if you see this slide, the brainstem has been bifurcated into two components. And even with this bifurcation of this tumor into two components, the symptoms may be very, very marginal, maybe some ataxia here and there. And now the question posed before you is to remove this tumor. One thing you must remember that this is an absolutely benign tumor. It is not a malignancy. It is a tumor which learns to live with the patient in a very symbiotic fashion. They learn to accept each other for a long period of time before one of the partners become a little bit weird and starts disturbing the other partner. Intraventricular epidermoids are extremely rare epidermoids, but they can be present in the ventricular cavity. Intraparenchymal epidermoid tumors are quite rare, and I will say quite extremely rare. Intra-fourth ventricular tumors, I will say they are rare, but they are not extremely rare. In my experience over the last 35, 40 years, I must have seen maybe about 15 to 16 fourth ventricular epidermoid tumor. I have written a paper on this subject also. Epidermoids can be small epidermoids when they present with symptom of trigeminal neuralgia, which is a very common symptomatic presentation of epidermoid tumor with hemifacial spasm, with trigeminal neuralgia. I will say trigeminal neuralgia is one very common symptom of presentation. Earlier in our days, we used to get this information that trigeminal neuralgia is diagnosed by virtue of symptoms. There is no need to do any investigation, but trigeminal neuralgia is quite frequently a presentation of epidermoid tumors and hemifacial spasm. These tumors are so benign and so long-standing that they can be the whole life, they can never present, and you can identify them in postmortem examination. For some other reason, you have done postmortem examination and you find epidermoid tumor in a postmortem specimen. And I have actually got epidermoid tumor when I was doing some cadaveric dissections. So epidermoid tumor is sometimes quite discreetly silent tumor, gentlemanly tumor throughout the life without disturbing the host. Sometimes they can be present with some other tumors, like I had reported several years ago, in the presence of epidermoid tumor, in presence of some other tumor. So this was in presence of, there are two tumors here: progressive hearing loss, diplopia, right hemiparesis. Magnetic MRI shows lateral pontine enhancing tumor with CP angle epidermoid. So two tumors in proximity. I do not remember what the other tumor was. Maybe a glioma, maybe intraxial tumor, maybe some kind of other tumor. But there are two tumors here, and we had reported a collision tumor. So they can be in collision, and this is actually a post-operative image where the tumor has been resected. So they can be huge. You see, these tumors can be huge, and they can go in every nook and corner, but they have some special surgical, they give way in a special way, which I will show you. So this is another huge tumor. In my world of epidermoid tumor, you can imagine, I will say this is quite a straightforward surgical problem. Another space which is not very commonly occupied by epidermoid tumor is cavernous sinus. You see, its cavernous sinus is a CSF cistern with Merkel's cave, so it can occupy the space of cavernous sinus. This is a beautiful tumor. You see, this is cavernous sinus part, and like a trigeminal neurinoma. I was showing you the other day, trigeminal neurinoma. Similarly, exactly same anatomy between the dural spaces of the trigeminal nerve, and this is in the posterior cranial fossa. Of course, here it will be in the subarachnoid space. So this is like a trigeminal neurinoma. So we had reported this giant multi-compartment epidermoid cyst of the cavernous sinus. This one, multi-compartment like a trigeminal neurinoma. This is another tumor where I had recently demonstrated this by surgery from here to London in a course organized by George Samandouras in London, where we were supposed to operate in our own country and show it in London. So I demonstrated two cavernous sinus tumors in that course from here in one course, and in the other course I demonstrated 5 cases. I am not sure if anyone of the panelists had attended that course, but this is one tumor I have shown live. And there were several participants sitting in London where I had opened the cavernous sinus to remove this tumor, and this is post-operative image. Intracavernous location of epidermoid tumors is a relatively rare location. This is that case again, which I'm showing you. Intracavernous like epidermoid, and this is post-operative image showing the tumor resection. This is another case of interdural cavernous sinus of the epidermoid tumor. This is the tumor in the cavernous sinus, and this is post-operative. You see how the interdural resection has been done inside the cavernous sinus. This location is relatively rare. I had another huge case like massive trigeminal neurinoma massive interdural cavernous sinus tumor, epidermoid tumor, and you can see the erosion of the temporal brain. This is another case. You see, this is inside the Meckel's cave and in the cerebellopontine angle. And I don't like to call that cerebellopontine angle tumor, and you will know very soon why, because I like to call them tentorial-based epidermoid tumor, because these are based on the tentorium, and then they go above the tentorium and below the tentorium in proximity to the brainstem, and then in proximity to the basilar artery and to the proximity of other very important cranial nerves in this vicinity of this tumor. This is another tumor in the tentorium-based epidermoid tumor. Now, sometime I showed you yesterday that this can be very similar. Dermal tumor is endodermal tumor, which can be exactly in front of the brainstem. The imaging features are discrete, but sometimes these imaging features can be similar to an epidermoid tumor. They have soft calcification. Basilar artery is in very close proximity to these tumors. They are relatively very straightforward tumor because the content of the tumor is like fluid, and like you can easily suck away that fluid. This is another endodermal tumor. I showed you that these are rare tumors, but they can be simulating epidermoid tumor. I had reported 7 cases because the last at that time. Now I have about 32, 33 cases of these endodermal tumors. They are dark on T2, bright on T1. Just open the capsule with a very small exposure, evacuate the cyst content, and then remove the wall as much as possible. And this is the postoperative image. And the patient recovers quite dramatically. Another dermal tumor is teratoma, which can be quite common tumor, not very common, but a tumor in the pineal region. More commonly, these tumors, teratoma, are identified. And of course, teratomas can be anywhere in the body, but more common in this region. This is another beautiful tumor that I have actually reported. And you see, this is a tumor like a beautiful shellfish tumor, I like to call it. And this tumor we had reported. This is another huge epidermoid tumor. So I'm taking you to my world. This is a dermoid and ruptured dermoid. You see this ruptured material inside the subarachnoid spaces of the brain. Ruptured dermoid is a common tumor of the brain. And when it is ruptured dermoid, the contents are like epidermoid tumor, but they are the capsule is very thin, and that is why it disseminates into the brain. You don't have to remove this tumor. You have to remove the bulk of the tumor here. So imagine this was my experience till 2008, about 12 years ago. After that, I have never written on this subject. And if I collect, you see 135 cases, so very big experience even at that time. Now, of course, in the next 12 years, my experience is quite a huge and no question, largest experience in the world on these tumors. Now, let us go on the surgical issues of these tumors. Surgical issues is that one is we must know ourselves very clearly and very definitively that these are very, very benign tumors of the body. They have very slow growth. When they come to us or when they are diagnosed, many of the times they come with very large sized tumors. Symptoms are quite marginal. They have an invasive pattern of growth. Symptoms are very subtle and they are located in critical location of the brain. So these are the issues that we must remember.
Okay, well, everyone knows the fire drill. There's an outage in the area is.
Yes,
Oh, okay,
John.
it popped right back.
Yeah,
Okay, okay. Carry on.
So these tumors are slow growing, benign tumors, large size, invasive in nature, subtle in symptoms, critical in location. So the more important thing is you have to remove the content of the tumor. That is one thing. Second thing is you have to remove the wall of the tumor. The wall of the tumor is actually the main culprit, which gives the tumor arises from the wall, epidermal wall, epidermoid. But the wall of tumor can be a little bit more dangerous to remove. So remove the wall as much as possible, more aggressively, but you cannot compromise any single. The bottom line is you cannot compromise on any single perforator or any single nerve. More importantly, suppose you damage the sixth nerve, the patient will be never happy. So it is a thankless operation, difficult operation at times, and a thankless operation. Frequently, these tumors can be quite incidental. Sometimes they will be associated with collision tumors, and I like to call them anterior tentorial-based epidermoid tumors. And if you see this slide, I wish you can see this article of mine in the year 2006. And I must tell you, I know the panelists sitting here, and I can tell you that this article is a revolutionary article in the subject of epidermoid tumors. Revolutionary. You will ask me why. And I have to answer this tumor because these tumors are not CP angle tumors. These tumors go up above the tentorium, below the tentorium, and along the tentorium. They are never actually only CP angle. They are in the cerebellomedullary fissure, in the cerebellum midbrain fissure, and they go above the tentorium in the region. And if you know that they are along the tentorium, then you can, most astounding approach is supracerebellar approach to these tumors. And I have done several tumors of this kind, supracerebellar. And the most intimate relationship of this tumor is with trigeminal nerve. And I have even speculated the trigeminal nerve relationship with these tumors, why the trigeminal is associated with epidermoid tumor. In this article, I had mentioned that because it supplies the skin, maybe some kind of a relationship with origin. Supracerebellar, first time in the literature we describe that CP angle is not the approach for this tumor. Supracerebellar is the approach for this tumor. Then you debulk the tumor because they have special characters. You debulk the tumor, then you cut the tentorium and go above the tentorium. So then you remove this tumor. Once you get a space, then you come in the CP angle in the vicinity of the cranial nerves. Most dangerous cranial nerve in this tumor is the sixth cranial nerve. And that cranial nerve you have to protect. And that is the main cranial nerve that will be a troublesome cranial nerve for you, because that cranial nerve has to be preserved, and this is post-operative scan. If you damage the sixth nerve, you have damaged this person. That is one thing that you can damage. If you damage any perforator in the vicinity of the basilar artery, you have damaged the person. You cannot damage anything, and that is a challenge for the surgeon. So I will like you to read this beautiful article of mine. This was the largest series at that time. And of course, this was 15 years ago. And now in the 15 years, I have got a very big experience. And at that time, my experience with pineal region tumors, epidermoid, was also the largest in the world. 24 cases. So on the strength of my experience, I'm going to give you my presentation, and I will give you, because I know many young residents are sitting, I will give you a message as to how to remove these tumors. So these tumors can frequently be presenting themselves with trigeminal neuralgia, hemifacial spasms, and things like that. And these tumors, this is preoperative tumor. You imagine the relationship with the brain stem. Imagine the relationship with various structures around the vicinity, basilar artery going in this region in the temporal brain. So I have told you that these tumors should never be removed from the CP angle. The cranial nerves are displaced laterally by these tumors. The best shot on this tumor is supracerebellar, and this was a revolutionary article of mine. These tumors are based on the tentorium. They go into all the kinds of fissures that you have heard of. And more importantly, they go in front of, above the tentorium, a large component of this tumor. They encase the basilar artery. The perforators traverse through the tumors. Cranial nerve, sixth nerve is in the vicinity of the tumor. Fifth cranial nerve is more often displaced laterally by the tumor. Seventh and eighth cranial nerves are displaced laterally by the tumor. So that is why I like to say that is why I was saying that this paper of mine is a revolution in the field of epidermoid tumors, and you have to say, you have to accept that. And also I have to warn you that for some time between 6:20 to 6:30, my internet connection will disappear, because I don't know why, but this time they don't like me to work. But I will show you as much as I can show you. Very rarely these tumors can be associated with some calcification. These calcifications are extremely rare. Basilar artery encased tumor above the tentorium, below the tentorium, in all the fissures that you have heard of. You see this preoperative image of this tumor, you see, and this is postoperative image. You see the various vessels within the confines of the tumor. This is another tumor. I think you have seen this. This is another huge tumor above the tentorium, below the tentorium. Huge tumors have been my forte, because many of our patients, particularly
Okay, we may be frozen here. Just hang in there.
Yes, my dear friends, again, I'm back. So many of the tumors that I have seen are quite huge. You see 10 centimeter anteroposterior diameter, this, that. So fantastic experience when I had reported this material. So many of these tumors are in younger population. After 40, they are quite less. Males are more frequently affected. Duration of symptoms are subtle, small symptoms, marginal headache, marginal giddiness, marginal ataxia for a long period of time. So many patients present with more than 5-year experience symptoms, 2 years, 5 years. So that is the kind. So let me discuss with you tentorium-based epidermoids, which is a new terminology that I had given, and I have no question that there is no other terminology for these tumors. If you call them CP angle epidermoids, it is a wrong terminology. Tentorium-based epidermoid tumors, the fifth nerve is maximally displaced laterally. Seventh and eighth cranial nerves and ninth cranial nerves are displaced laterally. Sixth nerve is usually displaced inferiorly. You see, there is no fixed character of this tumor. They can be displaced in any kind of direction. But in general, they will be displaced in this kind. They can go into cerebellar brainstem fissures. The membranes, they will very rarely, extremely rarely go into the substance of the brain. Arachnoid membrane is intact. They can be anterior to the brainstem. More importantly, they are above and below the tentorium in almost all cases. So you know what, John?
Yeah.
It gives the panelists some time to relax from this high power philosophical kind of. So you just relax, okay? If there are some interferences, just ignore them. So headache is quite a common symptom. Gait disturbance, facial numbness, vertigo is a very common symptom. Diplopia, trigeminal neuralgia is a symptom. Hemifacial spasm.
Getting temperamental today.
Yeah.
Yeah, back and forth to the internet.
Okay, so the symptoms are quite varied. More important is these symptoms are long-standing and these symptoms are subtle, not very intense symptoms. So now when we are asked to operate these tumors, what are your good points and what are your bad points? So one is that these tumors are very soft and suckable tumors. The brain is quite lax. It is not a tight brain. So these are good for the surgeon. Negative points for the surgeon are that the distortion are quite intense. Brain and cranial nerves and blood vessels are markedly distorted. They can encase the major vessels and perforator, and this multi-compartmental nature is another very big issue. Now I would like to show you some surgical cases. Now, my surgery for tentorial-based epidermoid, I divide them into 3 stages. First stage is always supracerebellar revolution in the field of epidermoid surgery, supracerebellar. Second stage is cut the tentorium if necessary, then go supratentorial. And the third stage is resect the part in the CP angle.
It's worse than usual today.
Okay, gentlemen. The most important and critical nerve in this situation is the bilateral sixth nerve along the clivus. And of course, the third nerve along the tentorium are very critical nerves. And more important is that if you want to save this person, you have to save each and every perforator from the basilar artery, which can be quite furiously intimately related to various structures in the vicinity of the brainstem, and this is postoperative scan. This is another tumor. You see it is above the tentorium, below the tentorium, in every nook and corner, and you have to be aggressive in your surgery. You have to come in the supracerebellar, remove the tumor, soft tumor, debulk the tumor. I will show you one video very soon. And then you have to cut the tentorium, go above, you have to reach the pituitary stalk. Sometimes you can see the chiasma, you can see the internal carotid artery. And I'm going to show you one case which is completely unedited tape. I'm going to show you for at least half an hour, so be prepared. And I don't want to edit that tape to show you the removal of the tumor in all nooks and corners. So this is preoperative. You see how it is going, and this is post-operatively the tumor is removed. Now, other thing which I want to tell the young people very, very clearly, complete tumor resection is important. Removal of the wall is important, but that is not your trophy. What is your trophy is to preserve the patient intact, because there are many critical structures in the vicinity of your surgical trajectory, vicinity of the tumor. Softness of the tumor allows you to remove these tumors, but you are not allowed to damage any single vessel or perforator or cranial nerve. That is why I say these tumors are quite thankless operation, but these are beautiful operation on a beautiful tumor. And that is beautiful tumor is epidermoid tumor. So this is the tumor of a different kind where you have to come in this direction. This is postoperative. So many of these tumors are in the ambient cistern. Many of the tumors are, the surgical direction has to be supracerebellar. It is only rarely that you have to come from the Sylvian fissure, from the pterional approach, like in this case, where the tumor has been removed from the basal subtemporal approach. This is preoperative and postoperative image. This is another tumor, preoperative and postoperative image. Tumor has been resected quite beautifully. This is another preoperative and postoperative image. So this is preoperative and postoperative. This is the tumor. Let me, John, I will like to show one full-length video, full-length surgery. Okay, John, are you ready?
Yeah,
So can you get me off the screen?
yeah, okay, second.
And there will be no editing, that you must remember. No, wait. Yeah, diffusion weighted is the most important image. What we will do is, let me first show you. John, get me, okay, just a minute, please.
Oop, we fell off there.
Let's get the video, John.
No, you didn't share the video. You open the video, then share it. There's no
Okay,
sound.
you have the video
Is-
on?
Yeah, is there any sound on it or no?
John, this video is on?
Yes. Think. You can see it, right, Dr. Gwell?
Okay, can you see that, John?
I can
Yes.
see.
Yes.
I cannot hear you, John.
Oh, you can't hear me? Can anybody else hear me? Daddy?
Can you hear me, John?
Yeah, I can hear you. I can hear you.
The video is on. We are seeing it.
Yeah, we're seeing the video and you are on. We can hear
Okay,
your voice.
can you hear me, John?
Yes, yes.
Okay. Okay, so this is the transverse sinus. This is some mastoid air cells. So this is the transverse sinus. Here is the sigmoid sinus, extra sinus quite widely. Can you see that transverse sinus? Here is the sigmoid sinus. And this is the cerebellum, little bit wider exposure. And marking the dural incision, as you can see. My dural incision is in the form of two flaps so that I can work in the supracerebellar compartment and in the retrosigmoid compartment. And I am going to show you largely an unedited version. Maybe I'll show a little bit editing here. Okay, so now here I am going supracerebellar. Now you see the fifth nerve is directly in my view here. And if you can imagine, if you see, there is tumor medial to the fifth nerve. So first thing is to take the petrosal vein very early in the operation. Because if you don't take the petrosal vein, you cannot retract the cerebellum properly. So what I'm doing is I'm trying to take the petrosal vein early in the operation so that I can retract the cerebellum. You must remember this is completely unedited version of this case. So it may not be like what you see in various where there is editing of the tape. So what I have done is I have cut the petrosal vein. I'm going supracerebellar. I'm seeing the tumor medial to the laterally displaced fifth nerve. This is the fifth nerve. I'm taking the petrosal vein because that is important step of this operation. Then you see, you have to now see that this beautiful pearly tumor is right there, and you have to break into the tumor. The good points is the brain is not tight at all. You have to open the cisterna magna initially to relax the brain, and then you have to break the tumor. You see, I am breaking the tumor. Breaking the tumor, breaking the tumor. You see, this is soft tumor. That is the beauty of this tumor. That makes this tumor very, very I will not say easy tumor. There is no tumor easy in neurosurgery. This is the fifth cranial nerve. Then I'm breaking this huge tumor which is going everywhere. It is encasing the arteries, and I may not be able to even label the nerves for you. Just imagine what is going on and what is not going on. Imagine.
Oh, we're getting too lucky there.
I will little bit open the voice also here. During that workshop was questions you're happy to hear the questions that were asked during that time. This is a workshop. There were about 200 participants in that workshop. So can you hear the voice, John?
We can't distinguish. I can't understand it. I can hear it,
No,
but we can't.
but voice of the my operation voice.
No, I do.
because
We can. No, we do not.
We hear my voice, the operation voice.
No, we don't hear the intraoperative voice. It could be a bandwidth issue. You can hear the voice vaguely.
Voice is okay, John?
We don't hear the intraoperative voice.
You don't hear?
No.
Okay, so then I will go on maybe just talking.
Yeah, you can comment on it.
So I'm just breaking the tumor. You see this tumor? I am holding tumor. You see, I am breaking the tumor, and above the dome of, and you see the brain is relaxed, supracerebellar approach. Did you get that approach? The most beautiful, astounding approach described for tentorial-based epidermoid tumors. You see now there is brainstem here, and this is completely unedited version of the tape. You must remember this. And above the dome of the tumor, there is the third nerve. I'm breaking the tumor with my suction. I will say, if you ask me whether bipolar will come in picture, no, bipolar will never come in the vicinity of the surgery, because if bipolar has come, means you have made a very big technical error. That error can be quite devastating for the patient. It means you have taken some big. This operation was demonstrated in front of 200 people, and such workshops I conduct on a regular basis. And the participants I will like to invite, it is my open invitation to the participants to come and join one of these workshops. And I promise you, I will never leave you disappointed. That is my promise to you. Now I'm removing the tumor along the tentorium. With the help of my suction, I am breaking the tumor. You cannot hear the voice of my suction, unfortunately, but try to imagine it. Try to imagine I'll see if I can show you the voice of this also. Now I'm trying to remove the tumor above the tentorium. More often than not, I will cut the tentorium. In majority of cases, even in this case, I think I will cut the tentorium at a later stage because the part of the tumor above the tentorium cannot be accessed. You see, these are relatively easy tumor to operate otherwise. You have to use your suction in a very, very fantastic manner. You learn to operate with your suction. The tumor is a very, very fantastic tumor to operate. This has come in picture. You must remember my exposure is supracerebellar. My entire exposure is supracerebellar. And now I am seeing right in the region of the hypothalamus, pituitary stalk will be here, pituitary gland will be here, posterior clinoid process will be here. This is the posterior cerebral artery.
So earlier you used to never complain about big things. No?
You must remember that this is unedited version, so there is some time, I don't know why time is being spent here. But these things, maybe I go a little further.
So bare necessities of life. Very nice. Third and fourth.
You see, this is the third nerve. See, you can use an endoscope sometimes to use, but it is not, usually it is better to cut the tentorium. Protect the fourth nerve and cut the tentorium.
The endoscope in your hand. Oh, is there?
Whoop. Fell off. He'll be back.
Can you see the pituitary stalk here? This is the hypothalamus pituitary stalk. And you see, this is the view from the supracerebellar. You can see, depending, the anatomy of the tumor, you can see the various structures. Let us see how far this has gone. I don't remember what this case was and how much was removed, but just this was in the workshop. Now this retrosigmoid exposure, you see, I have come retrosigmoid for a long time, that thing. I am breaking the tumor with my suction. You see supracerebellar approach. This is retrosigmoid now here a little bit. Sixth nerve is going to be the most important nerve. So we have to protect the sixth nerve in this area. This is the fifth nerve here. Sixth nerve is going to be here somewhere. This is the third nerve there.
Dr. Goel? Hello, Dr. Goel?
Just enjoy the dissection, my dear friends. This is you see, now you see here, I am going from the supracerebellar approach to the internal carotid artery is there. You just keep a watch here on the internal carotid artery. This is the fifth nerve. This is the third nerve. This is the internal carotid artery. This is the opposite optic nerve, opposite side. See, this can be removed. It gives you a very easy. This is the hypothalamus that you see here. Pituitary stalk is here. Here is the clinoid process and supracellular area, pituitary stalk. This is the region of the trigeminal Meckel's cave. This is completely supracerebellar and retrosigmoid combined. Initially was supracerebellar. I hope you are enjoying, young participants. This is epidermoid. These are the world of epidermoid tumors. So as I have already told you, I have got a very, very fantastic experience on these tumors in my lifetime.
Professor Goel, there is a question from someone here. He's asking if you do use lumbar drain or ventricular drain.
Did you hear that, Dr. Goel?
See, the brain is lax in this situation. That is the advantage. The tumor is soft. But problem is this intimacy of the relationship with the structures. You see here how intimately it is associated with the cranial nerves. That is the sixth nerve underneath here. Sixth nerve. This is the fourth nerve, third nerve. Pecom artery, posterior, pecom and posterior cerebral artery then will come. This is the pecom on the other side here. This is the internal carotid artery.
We got 4, 5, 6.
See, because you know, this tumor was operated some time ago. I don't see the see, this is the sixth nerve, and I am protecting the sixth nerve. It is the most important thing to protect the sixth nerve, as I have mentioned. You see, your handling of the tumor cannot, you know, it looks very good, but you can damage the person very bad. The bottom line of this operation is you have to remove this tumor as radically as possible. This is the fifth nerve. You see how fifth nerve is displaced towards you? This is the large fifth nerve. So you have to remove the capsule, but that does not mean see, I am breaking this epidermoid tumor. This is the large fifth nerve. Here is the seventh, eighth nerve complex. The most important thing is you cannot damage anything. As long as you are sure that you are not damaging anything, you can continue with your operation. As soon as you identify that, oh, there can be some damage by my dissection, you have to necessarily stop. See, here is the sixth nerve here. See, the sixth nerve is here. You see, here is the basilar artery. So most of the tumors will be of this kind of consistency. And here is the basilar artery. You see, most important thing which I am trying to show you is my exposure. And as I mentioned to you, supracerebellar approach to these epidermoids, which I like to call Tentorium-based epidermoid, is one of the most revolutionary approach to these tumors. And you should not have any doubt about it. If this tumor comes your way, you have to, without any question, you have to do this way. Now you see I'm dissecting in that area.
Hello, Dr. Goel. I think we're going to have to wrap it up soon. Dr. Goel? Hi, Dr. Goel. I think we may need to end this broadcast because we have the Jordan Neurosurgery Grand Rounds. I'd like to have Dr. Goel continue his golden education, but today the tech doesn't seem to be cooperating. So yeah. Does anybody have any comments?
Yeah, John, it's just about the question on lumbar drain. I don't use or prescribe lumbar drain. That the tumor is usually soft, is suckable, and it is white, very distinct from the brain. And therefore, if you use mannitol, it will suffice. You just get into the tumor. The moment you start sucking, like you said, you don't particularly need bipolar. The moment you start sucking the tumor, most of the brain will relax, then you have more space for maneuver.
Okay.
Thank you.
Okay, I wish Dr. Atul was here. Anybody have any comments on what Dr. Kanu had to say? Okay. Okay, well, I'm going to end this broadcast because we have to go over to the Jordan. Dr. Sabea, I have to set up for that. So thanks everyone for coming. Sorry about technical problems. It's worse today than usual. And I think Dr. Kanu, yes, go ahead. Yes, we have to go. Yes.
Yeah, we just hold on for 2-3 minutes, let him come back and then we'll end it.
Okay.
I think he's trying to come back.
Yeah, we have to end it pretty soon because I got another webcast.
Okay, fine. So we just give it a few minutes and
Yeah,
then...
sure.
Okay.
You have to pamper the star player.
John, are you there?
Yes, I am.
Okay, it appears Professor Goel is not responding.
Well, his associate, Dr. Abbey, mentioned that he's coming back in a few minutes. So I'm going to wait a few minutes. And if he doesn't come back, I have to go to Jordan.
Yeah, this is the usual.
This is,
yeah, it's unusual.
Probably,
yeah, it's unusually bad today, right?
Yeah, and this is the one this is the long one that always goes, I think.
Okay, well, maybe we can continue tomorrow.
Yeah, okay.
Okay, I'm sorry about that. Dr. Wells coming in there. Let me explain.
Yeah, we can tell him.
Yeah,
Thank you to Professor Goel. We appreciate everyone.
thank you. Dr. Goel, are you there?
Yeah, I'm there, John. Sorry for all this kind of things that are happening. But okay, now you are with me, John.
Yes, I have to go shortly. We have another conference soon.
So how much time we have?
Uh, we already went over, but 5 minutes, is that okay?
Okay.
To wrap it up,
So just let us wrap it up. Up till now, it was completely unedited, but now I will maybe little bit edit here.
We'll make it 10 minutes.
10 minutes, okay. Now you see how I'm handling the cranial nerves. You have to be absolutely sure that your handling is not going to damage the person. If you are not sure, you cannot do. That is the bottom line, you see. And this handling will depend on your experience with these things. See, this is quite a mega tumor. Many of these tumors can become very huge. They go here and there and everywhere. See, now this is retrosigmoid. This was supracerebellar. Most important is in this operation, there is no role for any kind of coagulation. These are the lower cranial nerves here. See, I'm breaking the tumor with my suction. This art of breaking the tumor will have to be learned. Unfortunately, there is no shortcut to it. Gentle suction, gentle. Little bit I have edited because John has to run away. See what a huge tumor that you are seeing. It enters into all. The symptoms are very subtle and minor. Duration of symptom is very long. The tumor is going along the tentorium, right in the ambient system. This is the brain stem here now. Supracerebellar approach, that is the key word in this operation.
Difference between acoustic and this. There is no blood to irrigate your.
Now you see, this is almost the end of the operation, I think. And you see the anatomy. This is the, see the cranial nerves you see here? Right from the hypoglossal nerve is here. You imagine the supracerebellar approach. And here is the internal carotid artery on the other side. Tentorium has been cut here. Okay, now what I'll do is I'll just rapidly show some slides. John, your slides are there with you?
Yes.
Okay. So this is the supracerebellar approach. I don't know whether this was the tumor I was showing. I am not sure. But this is post-operative of some other tumor maybe. And you can see the anatomy seen from here in the other side, the hypothalamus, the pituitary stalk, the internal carotid artery, and the tumor has been quite radically removed. See, more than radical removal of the tumor, it is the preservation of all nerves. It is the preservation of all blood vessels. So you can use, I had described contralateral approach to hemispheric tumor long time ago. And then I had described for meningiomas, for interaxial tumors. I had even described for interhemispheric AVM. You come, get these arteries first, and that's these veins later. This approach I had described. But you know what? This medial temporal epidermoid tumor, which is completely in the middle fossa, I had removed by lateral supracerebellar transtentorial approach. So this was the first article in the literature which showed resection of a supratentorial tumor by a posterior cranial fossa approach. Now, why I use this approach, there must be some special features in this tumor. Subsequently, if you've seen, this was in 2010, then there were many other papers written about removal of the cavernoma, this approach, and epilepsy surgery from this approach, but this was the first article on this subject. Pineal region tumors have their own characters. And of course, today I don't have time to show you, but this is a pineal region tumor. You see beautiful anatomy. You can see from here, from supracerebellar approach, the nose of the patient also can be seen. Of course, not the nose, but the entire territory, fornices and velum interpositum and things like that. Beautiful supracerebellar approach for these tumors. This is another epidermoid in this. And this is a huge tumor, which has, you can imagine the anatomy that must have been seen. This is air in the territory. You see the whole tumor from this territory, a beautiful anatomical demonstration of this tumor. Supracellular epidermoid is another wonderful, and these have higher recurrence rate, the supracellular epidermoid tumors, and the arteries of the circle of Willis has to be preserved in great perfection. This is supracellular epidermoid tumor, and I had one tumor which the tumor had become carcinomatous, squamous cell carcinoma developed in form of a collision tumor. So this was very rare case that I had reported. So thank you, ladies and gentlemen. And I hope you enjoyed a brief presentation on the world of epidermoid tumors. And I will be happy if you have some wonderful questions for me.
Well, I may have to cut you short there, Doc. I'm gonna go.
Okay. No
But,
problem. No
may-
problem.
Maybe tomorrow we can get to them. Are you lecturing tomorrow?
Okay. Yes, I will give you my title soon.
Okay,
And
great.
if I have some problem, then I will see, I will get another speaker for you.
Okay,
But there are some questions and I will answer them tomorrow. John,
okay,
and
excellent.
thank you very much,
Okay,
John.
thank you.
Unfortunately, it was a little disturbed presentation. Thank you very much, John.
That's
Bye.
okay. We'll see you tomorrow. Bye-bye.
Okay, John. Bye-bye. Bye-bye.